Everyone. It's a pleasure to be here, and at the outset, I'd like to thank all the organizing members of MAPICON for having me here. Uh, Dr. Bharti talked about estrogen deficiency and its effects in women, and I'll be talking about testosterone deficiency and a situation that we routinely see in our clinics. So I'll start with a patient. So this is a 54-year-old man who presents with lack of energy, easy fatigability, and lack of concentration. On detailed probing, he tells that he has decreased libido, and believe me, it's not very easy to ask these questions, especially if you are very young in your practice, and if you are asking these questions upfront, it becomes a difficult conversation. So what I usually do in my OPD is I start with, sir, energy levels कैसे हैं, mood कैसा रह रहा है, and then we start delving into sexual history. He also gave history of hot flashes for last 1 year. He has been hypertensive and he is obese. BMI is 30. On workup, he had low testosterone levels, and this part has become easier nowadays because if you are writing your patient to get a sugar level done, he'll come with a booklet of tests, and usually there is a testosterone level done in that. And I'll tell you the caveats of looking at those tests in my presentation, but we usually see these tests in that booklet as well. He also had dyslipidemia and he is pre-diabetic. How do we manage this patient? So let's start talking about hypogonadism. What actually is male hypogonadism? Male hypogonadism or testosterone deficiency is a clinical and a biochemical syndrome. It is characterized by low levels of testosterone, which are associated with signs and symptoms. So it is important that the low levels are also associated with signs and symptoms because 40 or 50% of the time it is a problem with the assay rather than the patient is actually having the problem. Uh, if I talk in strictly scientific terms, it is a reduced functional activity of the gonads. It may be low testosterone levels or inability to father a child. If we talk about epidemiology, and you'll be surprised what number of patients have this problem. Androgen deficiency increases with age. Incidence in middle age is around 2.1 to 12%. And if we talk about late onset hypogonadism, it is between 2 to 15%. And if I talk about Indian men, 20 to 48% prevalence in men above 40 years of age. And 40 years is a young age. This is the number of patients that we are talking about. There is an association, Dr. Kalra talked about obesity and metabolic syndrome. And in this situation, actually, the prevalence goes higher. It is around 45 to 58%. And this can be one of the motivating factors for management of obesity. I remember one of my patients who had come to me. He was married for past 3 years, and the problem was so severe that they were about to get divorced. When we took the history, there was reduced frequency of sexual intercourse, and he had hypogonadism. He had testosterone levels of around 150 nanogram per deciliter. He was obese. His weight was 108 kg, and we devised a plan. We were able to reduce 10% of his body weight in next 3 months, and eventually his intercourse frequency increased. He started feeling more energetic, and actually the couple were blessed with a child after 1 year of that. So this can be one of the motivating things, that just by reducing 10% of your body weight, you might be able to increase your testosterone levels by 10% or 15%. There is also meta-analysis on diabetes. The meta-analysis was done in around 6,400 men, and they showed that people with diabetes have lower testosterone levels as compared to non-diabetic people. Uh, Talking about endocrinology, uh, hypogonadism can be either hypergonadotropic hypogonadism, which is also called as primary hypogonadism, which we endocrinologists usually see where the problem is at the level of testis, and these patients have high LH and FSH and low testosterone levels. Or it can be a hypogonadotropic hypogonadism, which is low testosterone and normal LH and FSH, and this is the most frequent combination of tests that we see in our OPDs. It can be organic, where there is a proven pathology that affects the hypothalamic pituitary axis, and these have to be treated with conventional medications. Sometimes these patients require gonadotropins or testosterone depending upon the patient's situation. But more commonly, it is functional. There is no recognized organic alterations in the hypothalamic pituitary gonadal axis, and obesity is one of the root causes of functional hypogonadism. I remember my teacher, Dr. Amani, way back in 2012, she told me that obesity is an inflammatory disease and it leads to inflammation at hypothalamic levels. And this inflammation is responsible for hypogonadism in obese children. You see children with gynecomastia very commonly in your OPDs. Probably it is this hypothalamic inflammation that is responsible for low testosterone levels in these children. So these are the types of hypogonadism, primary and secondary hypogonadism. So which patient do we need to screen for? So men with relevant symptoms, what kind of symptoms? Most commonly it is erectile dysfunction, loss of libido, loss of early morning erections, and less commonly it may be delayed ejaculation, decreased volume of ejaculate, gynecomastia, sweating or hot flushes. If you start taking history, many of your patients will give this history if you delve more diligently in their problems. Or it may be seen in asymptomatic men. If you are looking into patients with chronic disease and there is a patient who is having anemia or osteoporosis or having recurrent fractures, patient is having unexplained weight loss, HIV associated weight loss, or there is a history of pituitary irradiation, or the patient is taking medications that affect testosterone production like opiates or glucocorticoids, these are the patients who should be screened for testosterone deficiency. There are certain symptoms that are very specific for testosterone deficiency, like incomplete or delayed sexual development, loss of body hair, very small testes, less than 6 ml. So these are very specific for testosterone deficiency. There are certain signs and symptoms that are suggestive, like reduced sexual desire, decreased spontaneous erections, breast discomfort or gynecomastia, unicoidal body proportions, inability to father children, or height loss or hot flushes. And there are certain non-specific symptoms like asthenia, low mood, anemia, loss of muscle bulk, increased body fat. So all of these may be associated with signs of testosterone deficiency. So what are the factors that determine signs and symptoms of low testosterone? It is the suddenness of onset. If the patient was having normal levels and he suddenly develops testosterone deficiency, maybe because of trauma or stroke, that patient will have very severe signs and symptoms. That patient will have hot flushes. That patient will come very early to you, as compared to those patients who have been chronically having low testosterone levels. Then it is the severity of androgen deficiency. A patient who has a testosterone level of 40 nanogram per deciliter will have very severe symptoms as compared to patient who has a testosterone level of 200 nanogram per deciliter. And then it also depends upon underlying cause. If there is an organic cause, these patients will be having more severe symptoms as compared to those who are having functional hypogonadisms. So there are certain conditions where total testosterone might not give you all the information and you will require to do a free testosterone levels. These are the conditions where sex hormone binding globulin are either reduced or these are increased. The most common situations that we look in our OPDs are obesity and diabetes. So this is one of the reasons why patients who are obese or who are diabetic have lower total testosterone levels. And there are certain conditions like hyperthyroidism, or use of estrogens or cirrhosis or hepatitis, in these situations, SHBG levels are increased, and these patients may present to you with falsely elevated testosterone levels. So this is the diagnostic evaluation. You have suspected hypogonadism, do a total testosterone levels done. If it is less than 200 nanogram per deciliter, it is very likely that this patient is having testosterone deficiency and further workup is required. If it is between 200 to 350, the condition that we most commonly encounter is this, where the testosterone level is between 200 to 350. In this situation, we need to measure a free testosterone. If free testosterone is also low, then this is also suggestive of androgen deficiency. So most of the guidelines say that you should use area-specific cutoffs for diagnosing testosterone deficiency. Most of the guidelines for routine purposes use a level between 2.7 to 3.5. 3 nanogram per ml seems to be the ideal cutoff where we should define testosterone deficiency in males. So at what time do we need to do the testosterone levels? So the problem with the tests that most of our patients bring to us is that they are done at any time of the day. And there is a definite variation. I'll show you in next slide. That testosterone levels reduce as the day progresses, and this may be associated with falsely low testosterone levels. So this was a study where where the authors looked into the level of testosterone early in the morning and compare it with the evening. You can clearly see that as the day is progressing, the testosterone levels reduce significantly. So these are the cautions that you need to take whenever you are doing a testosterone level in your patient. Always take a drug history. Take a early morning sample. What I advise to my patient is the best sample is between 8 to 8:30. Fasting sample, it may be earlier if you are getting up early, but fasting early morning samples are best. Ensure proper collection. Look into the drug history. Use a validated assay. Just while I was driving from Ganganagar to here, I got a call from one of my colleague that her daughter's testosterone level is 200 nanogram per deciliter. And just before I started my talk, I again received a call from him that he repeated the testosterone from another lab, and it is 45 nanogram per deciliter. So you can clearly see the variation in our labs. So you need to use a lab that follows the protocols, and that is the analytical errors are less with. Then we need to ensure post-analytical interpretation is correct. So I'll skip my slides because. So how we can replace testosterone? It can be given either as an injectable form, or as transdermal gel, or as oral capsule. So the problem with oral capsules is that it has to be taken repeatedly, and the effect is slower. With injection, the effect is faster, but it has a higher risk of increased hematocrit levels. With transdermal gels, the problem is that a large volume has to be applied all over the body, and especially in summer seasons in place like Bathinda or Ganganagar, it becomes problematic, and there is a real risk of transference to the partner. So these are the 3 formulations that are available. You can decide whatever formulations you need to use after discussing with your patient. How to monitor? You need to do a hematocrit. You need to look into the patient's liver function test. You need to look into the patient's PSA. And you also need to look clinically whether the patient is having unexplained aggression, sexual hyperactivity, or his alopecia is increasing, darkening of skin, or gynecomastia has increased. So these are the parameters that you need to look whenever you are replacing testosterone in your patients. So this is the treatment algorithm. I'll just forward you to follow up. So once you have given your patient testosterone, look into the improvement. If the improvement is satisfactory and the patient is willing to take injections, you can continue. If the patient is not willing to take injections now, after starting him on injectable form of therapy, you can either shift the patient on gel or oral form of testosterone. Or if the patient is not still feeling improvement, then you can either change or increase the dose of testosterone replacement. So this is a common problems that we see in this age group. Many of our patients have cardiovascular diseases, and if we look at the current guidelines, the Endocrine Society guidelines suggest that if your patient is having active cardiovascular disease, then these patients should not be initiated on testosterone therapy. If these are stable, then after discussion with their cardiologist, you may start these patients on testosterone therapy. In obesity and diabetes, there is definite evidence to suggest that testosterone replacement helps, and there is evidence that replacing testosterone in hypogonadal men in patients with type 2 diabetes definitely reduces the risk of mortality in this situation. And there is also evidence to suggest that lipid profile also improves if you are giving these patients testosterone replacement. We are worried about prostate cancer. My take-home message from this slide will be, it is the first 18 months that are important. So screen your patients more diligently in the first 18 months when you are giving your patients testosterone replacement, because this is the time when they can have prostatic problems. Otherwise, it is safe to use in this situation. So this was our publication with Dr. Kalra on management of hypogonadism in person-centered thresholds, targets, and techniques. So you can, it is freely available on net. You can read this publication. So my take-home messages are, testosterone deficiency is very common. It is important to take the sample early in the morning and look into all the caveats that I talked about whenever you are interpreting the results of the results, and look at the patient, and then decide whether this patient has to be given testosterone replacement or not. The patient there may be diverse number of patients which you are treating, and many of these patients may be taken care by one or other formulation of testosterone. Thank you.
Thank you, Dr. Atul Dhingra. Very nice presentation. Definitely, it is a very common sort of a problem, and not to be discussed among even doctors as well as our patients. So very nicely presented, and I think in future most of the people will take care of this thing. Thank you very much.
Thank you, sir. Thank you.